We're going to talk about PARP inhibition. This is a really hot topic in prostate cancer. Raul showed this table this morning. This is the summary of the data looking at germline DNA repair mutations in 7 metastatic prostate cancer series. As we see here, about 12% overall from these particular trials will have some form of DNA repair mutation. Predominantly, this is BRCA2, 44%, ATM, CHEK2, BRCA1. These are the other ones, and there are a variety of different other DNA mutations. And here's the microsatellite instability I was talking about before. It's 2% of all prostate cancer specimens. So why are we so concerned about this? Well, there is something called synthetic lethality, and PARP is an enzyme that has several different effects on the cancer cell. It's involved in DNA repair, transcriptional regulation, chromatin modification, mitosis, as well as in cell death. And there is a pathway to repair DNA once it becomes damaged. There's basically 2 systems. There's the double-stranded break, which is affected by homologous recombination, and there's a single-stranded break. So if you don't have the ability genetically to do this and to do this particular, go forth with this pathway, and you inhibit the single-stranded break pathway, which is where the PARP inhibitors inhibit this, the cancer cells apoptosis and die, and you can cause cell death. So the first clue that this was actually an active drug in prostate cancer came from the PARP study, which took 49 men with metastatic castrate-resistant prostate cancer who were docetaxel pretreated. 37% in the unselected patients responded. If you did a genomic analysis and prospectively obtained tumor specimens, 16 patients, or 33%, had some form of a DNA repair mutation, and this included BRCA2 and ATM as well as others. And then 67% had no mutations. 14 of those 16 patients responded, and only 2 of the patients without the repair mutations responded. So this set off a series of different trials. There's one phase 3 study right now, which is profound, which is Olaparib versus enzalutamide or abiraterone in men who have castration-resistant prostate cancer who fail second-generation anti-androgen therapy, and these patients are being stratified based upon their DNA repair status. There are actually a number of different agents that are being looked at in the single agent. Olaparib, rucaparib, and niraparib. Rucaparib recently reported the Triton-2 data showing about a 40% response rate in patients who had DNA repair mutations. And this, I think, is very, very exciting data. Now, we've gone one aspect, or at least we've looked at the patients that we can select. It's a small population, it's 12%. But how can we combine drugs to give ourselves a better chance of responding and giving clinical benefit? Well, there are 2 different ways that this can be approached right now. One is hypoxia, the other one is androgen blockade. Hypoxia will actually downregulate some of the genes involved in DNA repair. And in fact, if you look at DU145 and PC3, and you basically give them agents that can induce hypoxia, they can actually have reductions in some of the DNA repair enzymes, such as BRCA1 and BRCA2. There's an agent called Cediranib, which is an inducer of hypoxia, and this will basically, it's an anti-angiogenesis agent. It affects both VEGFR1 and VEGFR2, and it decreases angiogenesis, vascular permeability, and survival of new blood vessels. So we've at Yale been combining Olaparib along with Cediranib, and the hypothesis is that this has a higher response rate and progression-free survival than Olaparib alone. So it's actually a very, very interesting design because they're randomized to receive Cediranib or Olaparib by itself. Primary endpoint is progression-free survival. And if you were biopsying our patients, and if you if you're on the single agent arm, you then cross over to the combination arm. So we're actually testing a hypothesis if we can drive hypoxia and then see if we have responses. This trial closed to accrual about 2 months ago. So next year, I hope they'll be able to report the preliminary data from this particular study. There's a similar rationale for combining androgen blockade with targeted therapy, and the preclinical data suggests when you combine a PARP with agents that will inhibit androgen synthesis, that you can actually have synergy. And this is a study that was performed in animals in xenografts. Here is the control, and here is the combination therapy of androgen blockade plus a PARP inhibitor. Much better cell death. The reason for this is you're increasing BRCA, you're enhancing the blockade of androgen signaling, you're seeing decreased levels of DNA repair enzymes, and interestingly, you also induce radiosensitivity, which is, again, maybe possibly one of the reasons why we see synergy between this and external beam radiation therapy or androgen blockade. So there have been trials that have been performed that basically have been combining a PARP inhibitor plus abiraterone. This is an NCI study comparing abiraterone plus prednisone to abiraterone plus Olaparib. And when we look at the PSA declines, there was no significant difference in PSA outcomes or measurable disease or progression-free survival, so it did not meet its primary endpoint. If you're looking at somatic DNA repairs, there did seem to be a higher response rate in those patients with DNA repair enzyme mutations versus those who did not. Now, there's another trial that was recently presented at last year's ASCO meeting, different PARP inhibitor, Olaparib, combined with abiraterone versus placebo. Primary endpoint was radiographic progression-free survival. Overall survival, objective response rates were secondary endpoints. Well-balanced in terms of their median PSAs, about 86, extent of disease, and number of bone metastases. These patients could have had prior chemotherapy. When we look at the investigator-assessed radiographic progression-free survival, we do see a difference, and it's in favor of the combination. It's about a 5.6-month difference in progression-free survival. Overall survival, it's not mature yet, has a ratio of 0.91, but we don't see a difference at this particular point. Remember, that was not a primary endpoint. So if we start looking at DNA repair mutations in the tumor, there were 38 patients. Germline was tested, also plasma. 3, 7, and 13 respectively had mutations. And overall, the 142 randomized, 96% have biomarker data, and this is consistent with what we've seen before, about a 15% rate of patients having DNA repair mutations. And these, again, range from BRCA2 to ATM to CHEK2, and again, typical of what we've seen. The problem with this analysis is these numbers are extremely small, but you do see that there does seem to be a difference in favor of the combination in those patients who have the mutated repair mutations compared to the abiraterone alone. Now, the problem with this regimen has been in the toxicity, particularly in cardiovascular events. There have been a higher rate of cardiovascular events seen in the combination arm versus the single-agent abiraterone arm, and 7 versus 1, and there was 1 thrombotic stroke in the Abi arm. There were fatal cardiac failure in 4, fatal ischemic stroke in 1, and then chronic cardiac failure in 1 patient as well. So this is something that needs to be of concern with this. There are other combination trials that are going forth, and the interesting thing is that the checkpoints seem to have activity in combination with the DNA repair mutations. Again, given the prior talk we had a moment ago, it's not surprising. But even in patients who do not have DNA repair mutations, we are seeing responses with the combination of Pembro or Olaparib, and I think that that's something that really does need to be looked into carefully. There are trials looking at different PARP inhibitors, different checkpoint inhibitors. So again, I think that this is going to really require good biomarker data for us to understand where this is going to go. So in conclusion, PARP inhibitors have activity in patients who have aberrant DNA repair pathways. Combination studies are evaluating the concept of reducing BRCA in DDR-negative patients and thus increasing the response rate of the potential population of patients who may be eligible for these treatments.